Namaste and welcome to this wonderful presentation. My name is Dr. Kedar Bakshi. I'm practicing implantologist for last 26 years. I conduct courses in implants, aesthetics, occlusion, full mouth rehabilitation with correction of dysfunction. Every implant dentist faces three pain points in daily practice. The first pain point is a traumatic extraction. It is very challenging to extract a badly broken down root canal treated tooth, especially when it is broken down at bone level. Extracting without destroying the buccal bone becomes a real challenge. The second pain point is the sinus. When available bone under the sinus is 5 millimeters or less, a lateral approach becomes necessary for most dentists, and this approach is not easy for everyone to take. The third pain point is ridge width. After extraction, if available bone in width is 5 millimeters or less, it becomes equally challenging. OsseoSure helps in all three of these pain points. That is, its foundation, biological respect, minimal trauma, and maximum predictability. Why are we drilling bone? We are drilling bone because manufacturers have not given us any other option. But now that option is available in the form of OsseoSure. OsseoSure will condense the bone, it will compact the bone, it will enlarge narrow ridges. At the same time, it can help you elevate the sinus floor indirectly, even when the available bone under the sinus is 2 millimeters or less. You will always get superior final torque and you can place implant with better angulation for aesthetics. In three-dimensional implant positioning, if your angulation is towards the incisal edge or cingulum position, you will always achieve better aesthetics. For that, correct angulation is required, and with the OsseoSure system, you can achieve it. Drilling alone will never allow you to correct the angulation. Let's come to treatment planning. Treatment planning is influenced by the available bone, both in quality and quantity. If bone is D1, D2, D3 or D4, that is from hard to soft, this is one way of classifying the bone for quality. D1 is dense compacta, D2 is dense compacta or coarse trabeculae, D3 is porous compacta and fine trabeculae, D4 is fine trabeculae. For the quantity of bone, I use Kalmage classification, which gives us division A, B, B minus W, C minus W, C minus H, and D. Division B minus W, C minus W, and C minus H are very challenging. And this is where OsseoSure system will help you. In division B and B minus W, OsseoSure helps with resplitting. In C minus H, in maxilla, it helps with indirect sinus elevation. And if division A bone is soft, it helps with bone condensation. For OsseoSure treatment planning, we consider bone in two dimensions. Bone will be either narrow or wide and soft or hard. From that, we get four quadrants. Quadrant 1, wide and hard bone. Here, you will continue your drilling protocol. There is absolutely no need for OsseoSure. Quadrant 2, wide and soft bone. Here, you will always think of OsseoSure for bone condensation. You will never use drilling. Pilot osteotome followed by directly the final C-series osteotome is possible. Quadrant 3. Now this is challenging situation. Narrow and hard bone. You will first use F1 tip to create horizontal split. After that, sequential widening with C-series osteotomes. At times, you may require partial drilling with pilot drill to relieve resistance. Mostly, it will be at crest or sometimes at the apex. Quadrant 4. Narrow and soft bone. You will start with F1 for horizontal splitting, then continue with C series. At times, you may require A series for the apical preparation. In narrow soft bone, mostly you won't need a series. This is simple, clear protocol given by OsseoSure philosophy. OsseoSure covers four domains: ridge expansion, atraumatic extraction, indirect sinus elevation, and ergonomic handling. We do not claim that only mechanical osteotomes are superior. At times, manual osteotomes are required because manual osteotomes give the tactile feedback to the dentist that mechanical osteotomes cannot provide. Your fineness comes from manual osteotomes. We always recommend a combined effort, mechanical and manual. Initially, you start with either mechanical or manual osteotomes. Then you do most of the work mechanically, and the finishing or the refinement you do with manual osteotomes. In OsseoSure system, we have P1 and P2 pilot osteotomes. The apical diameter of P1 is 0.5 millimeters. The apical diameter of P2 is 1.5 millimeter. Both have taper length of 8 millimeters, and at 8 millimeter diameter is 2.2 millimeter. P1 is used mostly in harder bone. P2 is used in softer bone. In hard bone, you may use P1 first, then P2 subsequently. In soft bone, after P2, you can directly progress to your final osteotome. It can be C3.6 or C40. The unique feature of C series is that all tips share a universal apical diameter of 2.1 millimeters. That means C2.8, C3.2, C3.6 and C40, all of them enter the osteotomy at the same 2.1 millimeter apical point. Their taper length is 10 millimeters and the crestal expansion progresses from 2.8 to 3.2 to 3.6 and to 40 millimeters. This is the crestal expansion phase. Control widening of crest is achieved. After crestal bone preparation, you can think of preparing the apical bone. Normally, when we drill an osteotomy in hard bone, there is always the possibility that the crestal bone becomes over enlarged because resistance is at the crest and it destroys more bone than intended. And if you fail to reach the full depth at the apex, then two things will happen. Either your implant keeps rotating at certain depth without advancing, or after reaching full depth, you don't have sufficient torque. This does not happen with OsseoSure because at any given time, you can prepare bone apically as well. The A series osteotomes are designed for this. The system is universal. You can use it for any implant design. There is 0.7 millimeter difference between apical and crestal dimensions. For A 3.2, the apical diameter is 2.5 millimeters. For A 3.6, it is 2.9 millimeters. And for A40, it is 3.3 millimeters. Now, you may ask, can I use C series tips for indirect sinus or can I use CF series tips for resplitting? The simple answer is yes, you can use C and CF series interchangeably, but it is always advised that you use C series for resplitting and bone expansion because the C series has bibeveled concave surface at the apex designed for lateral compression. The CF and AF series have flat, non-cutting surface, specifically designed to protect Schneiderian membrane. With flat tip, membrane perforation becomes virtually impossible. In indirect sinus cases, the bone is typically having less density. It is softer bone and the problem is insufficient height. In this scenario, you may initially use a pilot osteotome, perhaps P2, briefly either manually or mechanically. If you use manually, then you will get better tactile feedback of the bone density. Then you progress directly to your final osteotome tip. Most of the time it will be CF40. So in one osteotome tip or at the most two tips, your indirect sinus lift is complete. The chances of Schneiderian membrane tearing is virtually impossible if you follow the protocols. I will show you the case where I have achieved an indirect sinus lift in 0.75 millimeter of available bone. I don't expect everyone to start at 0.75 or 1 millimeter immediately. But all my students are successfully performing indirect sinus lifts in under 2 millimeters of available bone. So why not you? OsseoSure offers three handle configurations: straight, angled, and extra offset. We do not recommend using extra offset handles manually because in manual use there is less control over the offset geometry. But extra offset handles are very effective when used mechanically, particularly in the posterior mandible and posterior maxilla where access is limited. These handles are engineered for tactile feedback and clinical flow, forged not just with steel but with stillness. The periotome tips are very thin and flexible, almost 50 microns thin. They slide between the root and the bone into the periodontal ligament space and cut the periodontal ligament very effectively. The tooth loosens, and with any elevator or forceps, it comes out very easily. This is critically important. If you use a conventional elevator on a root canal treated, badly broken down tooth, the root piece goes on getting crumbled. With OsseoSure periotomes, it will not crumble. Once you have used periotome tip, at times you will use F1 tip to create a little more space. F1 enters the periodontal ligament space already created by periotome, and with that your extraction becomes simple and effortless. So OsseoSure helps in three ways. It expands and densifies, improving bone density, improving final insertion torque, and improving ISQ values. It elevates and protects, virtually eliminating the need for lateral wall approach by protecting the Schneiderian membrane during indirect sinus lifts. And it extracts and preserves, enabling successful extractions in all patients, all cases, while preserving the socket for immediate placement. Your surgeries become more conservative, the healing period is less, and you will not have any performance anxiety. You will always be relaxed and confident. The true test of any system is its performance within the unpredictable architecture of the human jaw. These are actual CBCT scans, real clinical cases where OsseoSure has been used in knife edge ridges and subsinus regions. By relying on controlled compaction rather than drilling, OsseoSure enables faster healing, minimal flap trauma, and stable long-term outcome. So, OsseoSure is your complete ecosystem. Initial access with pilot series and flat tips, ridge expansion with C and A series, sinus elevation with CF and AF series, and atraumatic extraction with periotomes. It preserves the bone and performs for you because when you give nature what it respects, it gives back what you need. May your work be peaceful, may your hands be precise, may the lives you touch transform. Thank you.